Welcome you. Today we're gonna see about syncope. I'm Mohammed Suhail. Syncope is a sudden brief loss of consciousness with loss of postural tone followed by a spontaneous revival. The patient is motionless and limp and usually has cold extremities, a weak pulse and shallow breathing. Sometimes brief involuntary muscle jerks occurs resembling a seizure. Near syncope is lightheadedness and a sense of impending fate without LOC. It is usually classified and discussed with syncope because the cause are the same. Seizure can cause sudden LOC, sudden lock, but are not considered syncope. However, seizure must be considered in patient presenting for apparent syncope because history may be unclear or unavailable and some seizures do not cause tonic-clonic convulsions. Furthermore, a brief seizure sometimes occur with true syncope. Diagnosis depends on careful history, eyewitness accounts, or fortuitous examination during the event. Pathophysiology. Most syncope result from insufficient cerebral blood flow. Some cases involve adequate flow but with insufficient cerebral substrate. Insufficient cerebral blood flow. Most deficiency in cerebral blood flow result from decreased cardiac output. Decreased cardiac output can caused by decreased disorder that obstruct outflow, cardiac disorder of systolic dysfunction, cardiac disorder of diastolic dysfunction, arrhythmias, and condition that decreases the venous return. Outflow obstruction can exacerbated by exercise, vasodilation, and hypovolemia, which may precipitate syncope. Arrhythmias cause syncope when the heart rate is too fast to allow adequate ventricular filling or too slow to provide adequate output. Venous return can be decreased by hemorrhage, increased intrathoracic pressure, increased vagal tone, and loss of sympathetic tone is often termed vasovagal or neurocardiogenic and is common and benign. Orthostatic hypotension, a common benign cause of syncope, results from failure of normal mechanism to compensate for temporary decrease in venous return that occurs with standing. Cerebral vascular disorder rarely causes syncope because most of them do not involve the centricephalic structure that must be affected to produce log. However, basilar artery ischemia due to transient ischemia attack or migraine may cause syncope. Rarely, patients with severe cervical arthritis or spondylosis develop vertebrobasilar insufficiency with syncope when the head is moved in certain position. Insufficient cerebral substrate. Central nervous system requires oxygen and glucose to function. Even with normal cerebral blood flow, a significant deficit of either will cause lock. In practice, hypoglycemia is the primary cause because hypoxia rarely develops in a manner causing abrupt lock other than in flying and diving incidents. Lock due to hypoglycemia is seldom as abrupt as in syncope or seizure because warning symptoms occurs. However, the onset may be unclear to the examiner unless the event was witnessed. Etiology. The most common cause are vasovagal etiology, idiopathic. Many causes of syncope never have a firm diagnosis but lead to no apparent harm. A smaller number of cases have a serious cause, usually cardiac. Evaluation should be done as soon as possible after the event. The more remote the syncopal event, the more difficult the diagnosis. Information from witness is quite helpful and best obtained as soon as possible. History of presenting illness should be assigned event leading up to the syncope, including the patient activity, position, and if standing, for how long important associated symptom immediately before or after the event, including whether there was a sense of impending lock, nausea, sweating, blood or tunnel vision, tingling of lips or fingertips, chest pain or palpitation. Length of time recovering should also be ascertained. Witnesses, if any, should be sought and asked to describe events, particularly the presence and duration of any seizure activity. Review of symptoms should ask about any areas of pain or injury, episodes of dizziness or near syncope upon arising, and episodes of palpitation or chest pain with exertion. Patients should be asked about symptoms suggesting possible causes, including bloody or tarry stools, heavy menses, vomiting, diarrhea, or excess urination, and risk factor for pulmonary embolism. Past medical history should ask about a previous syncopal event, known cardiovascular event, and known seizure disorder. Drug used should be identified, and diuretics, vasodilation, and antiarrhythmic family history should noted. Presence at young age of heart disease and sudden death in any family members are noted. Physical examination. Vital signs are essential. Heart rate and blood pressure are measured with patient supine and after 3 minutes of standing. Pulse is palpated for irregularity. General examination notes patient's mental status, including any confusion or hesitancy suggesting a postnatal state and any signs of injury. The heart is auscultated for murmurs. If present, any change in the murmur with the Valsalva maneuver, standing or squatting is noted. Careful evaluation of the jugular venous vein while palpating the carotid or auscultating the heart may allow diagnosis of an arrhythmia if an ECG is not available. Some clinicians carefully apply unilateral carotid sinus pressure during ECG monitoring with the patient supine to detect bradycardia or heart attack, suggesting carotid sinus hypersensitivity. Carotid sinus pressure should not be applied if the carotid blood is present. Abdomen is palpated for tenderness, and a rectal examination is done to check for gross or occult blood. A full neurological examination is done to identify any focal abnormalities which suggest a central nervous system cause. Red flags. Certain findings suggest a more serious etiology, like syncope during exertion, multiple recurrence within a short time, heart murmurs, or other findings suggesting structural heart disease, older age, and significant injury during syncope. Family history. Interpretation of findings. Although the cause is often benign, it is important to identify the occasional life threatening cause because sudden death is a risk. Clinical finding help suggest a cause in 40 to 50% of cases. A few generalizations are important. Benign cause often lead to syncope. Syncope precipitated by unpleasant physical or emotional stimuli usually occur in upright position and often preceded by vaguely mediated warning symptoms such as vasovagal syncope. Syncope that occurs most often when assuming an upright position suggests orthostatic syncope. Syncope that occurs after standing for long period without moving is usually due to venous pooling. Log that is abrupt in onset is associated with muscular jerking or convulsion that lasts more than a few seconds, incontinence, drooling, or tongue biting, and is followed by postcidal confusion or somnolence suggests a seizure. Dangerous causation suggested by red flag findings are syncope with exertion suggests cardiac outflow, obstruction, or exercise-induced arrhythmia. Such patients sometimes also have chest pain, palpitation, or both. Cardiac finding may help identify a cause. A harsh, late peaking basal murmur radiating to the carotid arteries suggests aortic stenosis. A systolic murmur that increases with Valsalva maneuver and disappears with squatting suggests hypertrophic cardiomyopathy. Syncope that begins and ends suddenly and spontaneously is typical of cardiac causes, most commonly an arrhythmia. Syncope while lying down also suggests an arrhythmia because vasovagal and orthostatic mechanism does not cause syncope in recommended position. Syncope accompanied by injury during the episode increases the likelihood of cardiac causes of seizure somewhat and therefore the event is of greater concern. The warning sign and slower log that accompany benign vasovagal syncope somewhat reduce the likelihood of injury. Testing. Testing is typically done in ECG, pulse oximetry, sometimes echocardiography, tilt table testing, blood test, and CNS imaging. In general, if syncopes result in an injury or is recurrent, the more intensive evaluation is warranted. Cardiac and brain imaging are not done unless indicated by clinical findings. Patient with suspected arrhythmia, myocarditis, or ischemia should be evaluated as inpatients. Others may be evaluated as outpatients. ECG is done for all patients. The ECG may reveal arrhythmia, a conduction abnormality, ventricular hypertrophy, pre-excitation, QT prolongation, pacemaker malfunction, myocardial ischemia or MI. If there are no clinical clues, measuring cardiac markers and obtaining serial ECG to rule out myocardial infarction in older patients plus ECG monitoring for at least 24 hours are prudent. Any detected arrhythmia must be dissociated with altered consciousness in order to be implicated as a cause, but most patients do not experience syncope during monitoring. On the other hand, the presence of symptoms in the absence of rhythm disturbances helps rule out the cardiac cause. An event recorder may be useful if warning symptoms receive syncope. A signal average ECG may identify predisposition to ventricular arrhythmias in patients with ischemic heart disease or in post myocardial infarction patients. If syncopal episodes are infrequent, an implanted loop recorder can be used for long term recording. Pulse oximetry should be done during or immediately after an episode to identify hypoxemia. If hypoxemia is present, CT or a lung scan is indicated to rule out pulmonary embolism. Laboratory tests are done based on clinical suspicion. Reflexively, obtained laboratory panels are of little use. However, all females of childbearing age should have a pregnancy test. HCT is measured if anemia is suspected. Electrolytes are measured only if an abnormality is clinically suspected. Serum troponin is measured if acute MI is suspected. Echocardiography is indicated for patients with exercise induced syncope, cardiac murmur, or suspected intracardiac tumors. Tilt table testing may be done if history and physical examination indicates vasodepressor or other reflex induced syncope. It is also used to evaluate exercise induced syncope if echocardiography or exercise stress testing is negative. Stress testing is done when intermittent myocardial ischemia is suspected. It is often done for patients with exercise induced symptoms. Invasive electrophysiological testing is considered if non invasive testing does not identify arrhythmia in patients with any of the following: unexplained recurrent syncope, unexplained red flag finding, ischemia, cardiomyopathy, and unexplained syncope. A negative response defined a low risk subgroup with a high rate of remission of syncope. The use of electrophysiological testing is controversial in other patients. Exercise testing is less valuable unless the physical activity precipitated syncope. Electrography is warranted. EEG is warranted if a seizure disorder is suspected. CT and MRI of the head and brain are indicated only if signs and symptoms suggest a focal central nervous system disorder. Treatment. In witness syncope, pulses are checked immediately. If patient is pulseless, CPR is begun and cardiac resuscitation is done. If pulses are present, severe bradycardia is treated with atropine or sectional extra transthoracic pacing. Isoproterenol can be used to maintain adequate heart rate while the temporal pacemaker is placed. Tachyarrhythmia is treated. A direct current synchronized shock is quicker and safer for unstable patient. Inadequate venous return is treated by keeping the patient supine, raising their legs, and giving IV normal saline. Tamponade is relieved by pericardiocentesis. Tension pneumothorax requires insertion of pleural cannula and drainage. Anaphylaxis is treated with parenteral epinephrine. Placing the patient in horizontal position with legs elevated typically ends with the syncopal episodes if life threatening disorders are ruled out. If the patient sits upright too rapidly, syncope may recur. Propping the patient upright or transporting the patient in an upright position may prolong cerebral hypoperfusion and prevent recovery. Specific treatment depends on the cause and its pathophysiology. Geriatric essential. The most common cause of syncope in the elderly is postural hypotension due to combination of factors. Factors include rigid, non-compliant arteries, reduced skeletal muscle, pump of venous return due to physical inactivity, and degeneration of sinoatrial node and conduction system due to progressive structural heart disease. The elderly syncope often has more than one cause. For example, the combination of taking several heart and BP drugs and standing in a hot church during a long or emotional service may lead to a syncope, even though no single factor might cause syncope. Key points: syncope result from global central nervous system dysfunction, usually from insufficient cerebral blood flow. Most syncope result from benign causes. Some less common causes involve cardiac arrhythmia or outflow obstruction and are serious or potentially fatal. Vasovagal syncope usually has an apparent trigger, warning symptoms, and few minutes or longer of post recovery symptoms. Syncope due to cardiac arrhythmia typically occurs abruptly and with quick recovery. Seizures have prolonged recovery period. If a benign etiology is not clear, driving and use of machinery should be prohibited until the etiology is determined and treated. The next manifestation of an unrecognized cardiac cause may be fatal. Thank you.